go on here. So Amit said very specifically that I should stick with 10 minutes of TVT trial and really nothing else. So I'm going to just present purely on the TVT trial. I'm not going to give you any of my biases or any of my own surgical issues. I have no financial disclosures related to this presentation. So, currently available glaucoma drainage implants in the community can be divided into non-valved implants and valved implants. And essentially, we're going to be talking about non-valved implants because that's what the TVT study used. So there was a great concern when the TVT study was conceived at about, the conception started about 2005, 2006. And there was a concern that we were seeing long-term complications of mitomycin use in trabeculectomy. And it's very interesting that you put my talk at the beginning of a trabeculectomy symposium. I think over the years, we have learned how to use mitomycin better. But way back in the early 2000s, we saw a lot of endophthalmitis and there was a lot of problems with blebs and bleb morphology. So tube shunts seemed to offer a better surgical approach, and nobody really knew what was the preferred alternative, especially in patients who had already failed a trabeculectomy. So if we looked at practice patterns in the United States comparing from 1996 to 2002, there was definitely an increase in tube shunts over trabeculectomies over a period of time. So at the Bascom Palmer Eye Institute, they set up this multi-center randomized clinical trial at various clinical sites across the United States to compare the safety and efficacy of non-valve tube shunt surgery to trabeculectomy with mitomycin C in patients with previous ocular surgery. So again, I will stress these are patients who had either failed a previous trabeculectomy with or without mitomycin or 5-FU, or had undergone cataract surgery. Even clear corneal cataract surgery with no conjunctival involvement patients were enrolled in the study. Inclusion criteria included patients with the age of 18 to 85. The intraocular pressure had to be greater than or equal to 18 millimeters of mercury or less than or equal to 40 millimeters of mercury. Again, we talked about how previous cataract extraction with IOL implantation failed a trabeculectomy or both procedures. Exclusion criteria, obviously we're unwilling to get consent, pregnancy, if the patient was blind. All secondary glaucomas were excluded. If there was posterior blepharitis or anywhere where you think that there's a risk for endophthalmitis with trabeculectomy, they were excluded as well. Again, if the patient was aphakic, there was vitreous in the AC, or he thought there was a need for a combined procedure with the cataract surgery or any other procedures, or a patient had previous conjunctival scarring like a buckle from retinal detachment surgery or something, they had to be excluded from the study. Two treatment groups, exclusively 350 millimeter square barrel glaucoma drainage tube implants we used. Now in India, you have the aqueous, the Aurolab aqueous drainage implant available, the RD implant, which is similar 350, so you can use a correlation towards that. All tube implants were placed in the supra-temporal quadrant, and there was flow restriction to the non-valve implants. The choice of flow restriction was left to the individual surgeon. So could I just be a vicryl tie, or could be an obturator within the tube or along with the vicryl tie. As far as trabeculectomy goes, all trabeculectomies were performed in the superior conjunctiva. The dosage of mitomycin used was 0.4 milligram per mil for total duration of 4 minutes. Pretty excessive in today's day, but that's what people were using way back when the study was conceived. Outcome measures were intraocular pressure, visual acuity, fields, quality of life, reoperations, complications, and need for supplemental medical therapy. Failure was defined as an intraocular pressure of greater than 21 millimeters of mercury or not reduced by 20% below baseline on 2 consecutive visits after 3 months. If the intraocular pressure was less than or equal to 5 millimeters of mercury on 2 consecutive visits after 3 months, it was also considered a failure. Any additional glaucoma surgery or loss of light perception vision is also considered a failure. Success was defined as complete and qualified, depending on whether there was need for supplemental medical therapy. The demographic characteristics were pretty similar between both groups. They enrolled 107 patients in the tube group and 105 patients in the trabeculectomy group. Average age was somewhere around 70 years. There was predominantly a female to male gender, and most patients there was a good mix of white and black patients between the two. And just that you know, black patients have an increased risk of keloid formation and scar tissue formation. So I think it's really important that you have a good proportion of black patients within the study. The baseline ocular characteristics, they started with an intraocular pressure of mean of about 25 millimeters in both groups. Both groups were at mean of about 3.3 medications, predominantly primary open-angle glaucoma. And these were all advanced glaucoma patients with a mean deviation of nearly -15 or -16 in both groups. So these are not early glaucomas, these are not moderate glaucomas, these are pretty advanced and significant glaucoma patients. So they randomized 212 patients into a tube and trabeculectomy, 107 in the tube group, 105 in the trabeculectomy group. At the end of 5 years, 69 patients completed the study in the tube group and 76 completed in the trabeculectomy group. 14 patients died in each group, and some missed follow-up visits along the way. So if you look at the treatment outcomes per se, looking at each year, starting at baseline, year 1, year 2, year 3, and year 4. So at the year 1 study, which they actually published, both groups actually achieved low teens, about 12.5 to 12.7, using an average of about half medicine and trabeculectomy and about 1.3 in the tube group. And when you go down to 5 years, the tube group was sitting at 14.4 millimeters of mercury, the trabeculectomy group at 12.6, and mean glaucoma medications of about 1.5 in both groups. So if you look at the intraocular pressure over the year, like I said, both started off over 25, and then if you went down at about a year, they were pretty similar at the end of 1 year. But now if you look at the end of 5 years, there seems to be a divergence. That, there was a divergence in that the trabeculectomy group was slightly lower and the tube group was slightly higher in terms of trabeculectomy, but in terms of clinical significance, there was no clinical significance between the two groups. The probability of failure at 1 year was 13.5% in the trabeculectomy group and only 3.9% in the tube group. But if you extend that to 5 years, in the tube group, the failure rate is about 30%, whereas in the trabeculectomy group, the failure rate rises up to about 50%. The number of complete successes is pretty similar in the tube and trabeculectomy group, whereas qualified success is a little bit higher in the tube group. There's no statistically significant difference between the failure rates in the tube as well as the trabeculectomy group. So what are the reasons most treatments fail? Most patients fail because of inadequate intraocular pressure reduction in both groups. There was also reoperation for glaucoma in about 7 patients in the tube group and 11 patients in the trabeculectomy group. Persistent hypotony seemed to be a problem more in trabeculectomy rather than the tube group. Now, when they went back and reanalyzed the data, there was clinical hypotony, or we call just numeric hypotony, where the pressure was below 5, so they classified it as a failure, but the patients retained good visual acuity and retained visual field over a period of time. And there were very few patients in either group that actually lost vision. There was loss of light perception in 1 patient in the tube group and 1 in the trabeculectomy group. So if you were to use stricter definitions of success, that is, if you failed with a pressure over 17 or failed with a pressure of 14, especially given that these are advanced glaucoma patients, the numbers change again. In the failure rate rises to about 53% of the trabeculectomy group for over 17 millimeters of mercury and rises up to about 32% in the tube group. Whereas if you go to the greater than equal to 14 millimeters of mercury, you can see that, again, there's a staggering and the failure rate increases. So what are the reoperations for glaucoma in the tube in both groups? So if you already had a tube put in, 4 patients had another tube put in. The other 4 had transcranial cyclophotocoagulation or a diode cyclophotocoagulation. 1 patient underwent an EC-pre, and eventually this ECP patient also underwent a transcranial diode cyclophotocoagulation. Patients who failed trabeculectomy, 15 of them underwent a tube shunt, 1 underwent a CPC, 2 of them underwent a bleb revision, and 1 had a trabeculectomy with 5 FU. Again, if you look at the total cumulative percentage of patients who had a reoperation, it's about 9 and 29. So the numbers are higher, 8% and 18% between the 2 groups. Again, not statistically significant. Early postoperative complications less than 1 month, again, pretty higher, much higher in the trabeculectomy group, given there were more choroidal and shallow anterior chambers. There was some wound leaks also included, but again, there was a little slightly statistically significant at that point. In terms of late postoperative complications, pretty similar between the 2 groups, but I'd like to point out a few ones here. One is diplopia in the tube group. Second is tube erosions in the tube group, and that's what you got to really watch out for. Whereas in the trabeculectomy group, they're it's mostly choroidal effusions and bleb leaks that trouble you in the long run. If you look at reoperations, again, pretty similar between the 2 groups, about 20 in the tube and 15 in the trabeculectomy group, not statistically significant. So if I were to conclude, non-valve tube shunt surgery had a higher success rate compared to trabeculectomy with mitomycin in the 5 years of follow-up. Both were associated with similar intraocular pressure reductions and use of supplemental medical therapy. Additional glaucoma surgery was needed more frequently after trabeculectomy with MMC than with valve replacement. Large number of surgical complications in both groups. The incidence of early postoperative complications was higher following trabeculectomy rather than the Barwell group, but the rate of late postoperative complications and reoperation as well as cataract extractions were similar in both groups. So to conclude, that the TVT study really does not demonstrate a clear superiority of one glaucoma surgery over the other, but really indicates that if you have a patient who has failed a trabeculectomy sitting in front of you in your office, you have two options. You can either choose to go the tube route or you could choose to go the trabeculectomy route. Your skill and expertise in dealing with these operations, as well as the patient's willingness to undergo repeat glaucoma surgery, will be an important factor in what procedure you are going to choose for that individual patient. Again, cannot stress enough that you cannot extrapolate these results to use with armored valves, because I know that in India predominantly armored valves are used, and you really cannot extrapolate these results to use of armored valves. Subsequent to this study, the primary tube versus trabeculectomy studies have been set up. Due to lack of time, I'm unable to discuss them today, but you can look into literature. The 1 and 3 year results have been published. So thank you very much for this, and I hope you got some critical pearls out of my presentation.